Good evening, everyone. Thank you for joining in today. My name is Erasmus. As introduced previously, I am a moderator and luckily a mentor of the day today. You are welcome to our sixth segment of the Pulmonary Madness, when we are reviewing lung function, lung physiology in critical care medicine. And this is brought to you by the two leading associations for pediatric medicine and intensive care. And we dubbed ourselves the SWACCS, which is a statewide anesthesia and critical care seminars. When we are live on YouTube, and recordings of past talks are also available on YouTube. More information is available on X, Facebook, and our website. The idea behind all this is to share information, share knowledge, inspire, and mentor you guys. And really quickly, we go to the previous session that we handled. That was the episode on restrictive lung disease. We had a nice session mentored by Dr. Preach. And we had a cast of presenters, starting with a clinical case by Dr. Daphne Atukwatse and Jonathan Mugenyi, taking us through the pathophysiology of restrictive lung diseases. Then we followed that with the physiological approach to therapy by Dr. Julia Caesar. Then we went into some futuristic stuff, hoping that we would hear something that will put the heart at bay. But what we learned really is that it's quite a horrible set of diseases with a very poor prognosis, and just a few things that we can always try to do to make our patients comfortable and maybe prolong their lives, make some quick decisions. If we can also get transplant where feasible. But for the most part, these are patients who might need a very good multidisciplinary approach that will involve palliative care early enough to support them. Session is recorded on our website, which is a click away. And I'll also share the link on the chat. A lot of things were spoken about this condition, but the biggest part is that it's quite a poor prognosis overall. And it's a set of diseases that are progressive, and by the time patients turn up in critical care, usually means that they are very sick and you may have very little to do to help them, except at least identify if there's something reversible that you can turn around so the patient can get better, but also do end-of-life discussions early enough, including involving palliative care, transplant medicine, pulmonology, just so that they have around-the-clock care, and also they are safeguarded in terms of avoiding unnecessary and expensive and painful therapies that are probably commonplace in the ICU environment. Today, we turning to the pleural space in critical care. And yes, we have a bit of a gory image. The background, this is a case that turned up, I believe, in Congo, of somebody who had trauma, but then got flesh-eating bacteria that involved the tissues there and digested his muscle and connective tissue right all the way to the pleural space, and was going into theater for some sort of intervention surgically. We will have our own session today, and it's going to be mentored by myself. Dr. Cornelius will join us in a bit as a co-moderator, and we have got quite a big cast again. So we shall have a clinical case by Dr. Melissa, followed by some discussion of diagnostics of diseases of the pleural space. Then we shall go to an idea about how to manage them. So as usual, we'd like to mute so I don't interfere. Share your questions in the chat, and then raise your hands to speak when the talks end. The moderator will pick you. So right away, we'd like to welcome Dr. Melissa, who's a third-year resident in the Department of Anesthesia and Critical Care at Makerere University College of Health Sciences, who will give us, take us through a clinical case relevant to today's talk. And yeah, so Dr. Melissa, kindly share your slides as I retire mine and start right away.
Are my slides clear?
Yes, the slides are clear and you're audible as well.
All right. Thank you, Dr. Erasmus, for this opportunity. So my name is Dr. Sechito Melissa, like Dr. Erasmus has introduced, and I'm going to do the case presentation. So we're going to start with the patient medical history, the assessment, which involves the initial assessment and the progressive assessments that were done, and the different lab investigations and imagings that were done. And we'll finish off with a summary of events and interventions. So this is a patient, KA, a 61-year-old male who was a referral from another hospital. He was a known HIV patient, ISS, known DM, known hypertensive patient, and known CKD patient. So he presented with difficulty in breathing for 2 weeks, left upper limb swelling for 3 weeks, and oliguria. So we're going to do a background medical history initially because he had quite a number of medical issues. So he was a hypertensive and type 2 DM for about 20 years, and he was currently on Lantus. 15 international units, and his most recent HbA1c at that point of admission was 7.1. He was also a post left CVA with residual right-sided weakness, which he suffered from in 2021, and he was ambulating on ticagrelor. He also had he's a CKD patient, probably due to the multi-infection. So he had it probably due to the HIV, DM, BPH induced. It was, we couldn't know, but he's a post-renal transplant patient, which was done 4 years ago in India. And he had his graft was functional. However, he was put off immunosuppression at the referral site. Before that, he was on MMF, which is a mycophenolate mofetil, tacrolimus, and prednisolone, which are all immunosuppressants. He had also suffered HIV disease for 20 years, and he was on Genovia with his admission CD4 count at 69. He also had BPH, and he was on tamsulosin. However, he had no complications, no hydronephrosis, and no history of recurrent UTIs. He also had a PCI done in September of 2024 with stent placement. He had had multiple transfusions at the referral site, as we shall see, and notably, he was allergic to sulfur-containing drugs. So at the facility he presented with difficulty in breathing, which was associated with orthopnea, chest pain. He had a dry cough, PND, and also lower limb swelling. However, no B symptoms. He also had the 3 weeks history of left upper limb swelling, which was associated with oozing of clear fluid from the skin, but no discoloration. He also had a spontaneous parectal and mouth bleeding. However, he had no abdominal pain and no nausea and vomiting. He also had reduced urine output, but however, there was no hematuria and no dysuria. He also presented with on and off confusion, slurred speech. However, he had no history of convulsions and no loss of consciousness. So before he was referred at the pre-referral site, he had stayed there for 15 days. And at the presentation at that site, he had presented with a 2-day history of difficulty in breathing. So then he was managed for the following. So he was diagnosed with this. where he was, this is a summary of that stay, where he was started on meropenem, linezolid, and he was given also ilnestatin. He was also diagnosed with a DVT of the left upper limb, and he was initially started on apixaban and later switched to Clexane. He also had bilateral pleural effusions, and they were able to do a pleural tap and took off 1.2 liters of hemorrhagic fluid bilaterally. It wasn't specified how much was per side. He was also managed for electrolyte imbalance, hyponatremia with hypertonic saline, a start dose, and continued with tolvaptan. He also had he also had AKI on CKD with fluid overload, and he was managed with a Lasix infusion. He was also diagnosed with severe thrombocytopenia, querying the cause. He received, during that stay, he received 6 units of irradiated platelets and 6 units of packed red blood cells, which were irradiated. They also started eltrombopag, and yes, however, his thrombocytopenia continued worsening. They held the suspected drugs, which could have, they were querying drug-induced thrombocytopenia. So they held Lasix, linezolid, and paracetamol, and he was also given a start dose of IVIG. During all this, he was still on ward. However, on day 8, during his stay, he developed severe hypotension, and he was admitted to the ICU. In the ICU, he was started on vasopressors, and then they stopped the immunosuppressants, the MMF and the PRED. They also switched to polymyxin B, the antibiotic. So at that pre-referral site, this was a CT done, and we can see that we see on the left we see a homogeneous opacity, and also on the right side of the lung. However, that we see that according to this CT, it was mainly the left side affected, and the diagnosis of pleural effusion was done. This CT was done before the tap. So at the referral at the site he was referred to, this was the initial assessment on arrival. So his airway was patent. He was spontaneously breathing with a tachypnea of 27 breaths per minute. He was saturating at 99% on 5 liters of oxygen. He also had a stoniidal percussion bilaterally, but was more marked on the left side. He had reduced air entry bilaterally in the lung bases, but more marked on the left. He also notably had fine crackles in the right supramammary and inframammary areas. In terms of circulation, at that point, he was stable, fairly stable. His GCS was 14 on arrival. And notably, he had reduced power on the right upper limb and lower limb of 4 out of 5. His RBS was 7.8. Per exposure, notably, he had the swollen left upper limb with large blisters, and notably had a temperature gradient. He also had blisters on the posterior aspect of his thighs bilaterally. Further assessment, notably, he only had 30 mils of clear urine, and this was reported to be over 5 hours. And then also notably, he had a CVC in situ in the right internal jugular vein. However, there was oozing of blood at that site. So at admission, These were the initial labs that were done. So an ABG was done. And we can see that he had a pH of 7.4 with a PO2 of 57, carbon dioxide of 28.7, which was on the lower side, and bicarbonate of 20.9. According to my assessment, this gave a picture of metabolic acidosis, probably chronic. His CBC, notably, he had a severe thrombocytopenia of 29. And his infection markers, CRP, one was 118.5, which was elevated. His urea and creatinine were elevated with a creatinine of 200 and a urea of 27.2. Also notably had a hyponatremia of 125. It also did a BD glucan, which was positive, and hence this patient was suspected for invasive fungal infection. Doppler ultrasound was also done for the affected limb, the left, which still gave the diagnosis of a DVT and cellulitis. The echo showed an ischemic cardiomyopathy with moderate systolic dysfunction. On the abdominal ultrasound, they notably reported enlarged transplanted kidney. However, there was no hydronephrosis. Yeah, so the CTPA, I was unable to get the images. However, the CTPA, they reported there was no evidence of PE. He had the left pleural effusion, which was also causing a left lower lobe atelectasis. He also had the pachypneumonic segmental consolidation in the right upper and right lower lobes. So at this point, we had the following problems. So we had the left pleural effusion occurring a parapneumonic effusion. So at that point, they started oxygen therapy. They continued the oxygen therapy via nasal prongs, and he was saturating well. And at this point, the intervention radiologist was consulted for a pleural tap. He was also started on Lasix for the fluid overload. For the severe thrombocytopenia, he was transfused with irradiated platelets and FFPs, and catheter changes were postponed. He was also started on antifungal medication in view of the positive BD glucan. Also, samples were taken off for blood cultures, and he was started on polymyxin B, and meropenem was continued. They also took off samples for urine lung, serum crag, and toxotiters. Hyponatremia was corrected with tolvaptan and sodium chloride tablets. So the pleural fluid analysis wasn't exactly conclusive. They reported they gave a cytology report, which was inconclusive, and they concluded an inflammatory effusion, which I think we shall dive into later. So the subsequent days, notably on day 2, he had the left chest drain inserted. However, during the procedure, he suffered a respiratory failure, which was suspected to be due to re-expansion pulmonary edema. So at this point, he was intubated and started on mechanical ventilation. He also, day 2, he also developed hypotension, and he was restarted on vasopressors, NORAD and adrenaline. Also, they started Entrobobag, which was restarted in this unit. Sorry, in this health center. And also they held the anti-failure medications. And he also received irradiated packed red blood cells. On day 3, notably, his bleeding stopped. However, he had a severe hypoalbuminemia, which is expected, and that was corrected with albumin, and notably the serum CRAG and TB-LAM were negative. So at this point, the nephrology team reinitiated the kidney immunosuppression. However, they only initiated tacrolimus and prednisolone. Also, rosuvastatin at this point was started. Anticoagulation was started. Sorry, rosuvastatin was started. And ivabradine was started. He also received more platelets and FFPs. Between day 4 and day 5, notably, his platelets rose to 153. However, his infection markers were continuing to increase. His electrolytes had corrected, and also notably, the results for adenosine deaminase returned, and they were normal. So at this point, they held correction of the hyponatremia. They switched from IV fluconazole to voriconazole, and this was based on the culture and sensitivity results that returned. Echorin was started by the cardiology team, and he was also weaned off adrenaline. So sedation was also stopped to try to wake him up, and also at the same time assess his level of consciousness. On day 7, they noted still increasing creatinine. At this point, we had about we still had an active chest drain with about 500 mils in 24 hours. His urine output was at 1.14 liters per 24 hours, but this was on Lasix. Like we said, the pleural fluid cytology report wasn't conclusive. So at this point, Lasix dose was increased. Yes, on day 8, he was still when sedation had been stopped 2 days ago, he was still comatose. So a brain CT was ordered, which showed the old infarcts and global atrophy. There was really no new opacity or conclusion. He was still on noradrenaline for BP support. So at this point, the Lasix dose was switched to infusion. The Lasix was switched to infusion, and he was also started on apixaban. On day 9, they noted decreasing platelets again. Yes, and constipation and hypoalbuminemia. Albumin was replaced by infusion. Due to the long stay, a track was done on day 10. And at this point, his platelets were at 70 and his HB was at 7.0. An EEG was done to assess, and it reported abnormal background rhythm suggestive of encephalopathy. At this point, the neurology team was querying viral encephalitis. He continued to receive platelets day 10. Between day 13 and day 15, he still had oliguria, despite being on Lasix infusion at 10 milligrams per hour. His creatinine was rising as well as his potassium. And at this point, the hemodialysis, the decision to do hemodialysis was made. And he received his first session of SLED. In this session, they took off 4 liters of fluid. Also significantly, he had started bleeding from the ETT, and the chest drain was still active with hemorrhagic fluid. So at this point, Echorin was held again, and he's continued receiving irradiated platelets. In the subsequent days, the infection markers continued going up, trending up. And at this point now, he had a leukopenia of 0.87. Blood cultures, there was nothing reported. However, on tracheal aspirate, they reported stenotrophomonas maltophilia. At this point, the antibiotics were changed to moxifloxacin and tigecycline. He had his second session of SLED, where they took off 3.5 liters. He still received packed red blood cells, and at this point, also vitamin D levels returned when they're on the lower side, so he received vitamin D replacement. On day 18, I noted his glands were necrotic due to the edema, the marked edema, and he had the urology team was able to do a glanzectomy and debridement. He had his third hemodialysis session, and they took off 3.5. Day 19 to day 20, he had worsening. He now had a pancytopenia with a neutrophil count of 0.07. He had platelets of 21 and white blood cells of 0.21. So at this point, still continued transfusion to correct that. And he was tried on CPAP. He had a trial of CPAP. He had a trial which he failed. He had another SLED session where they still took off 3.5 liters. His underwater seal, his chest drain was still active at this point. His urine output at this point was 0.1 mils per kg per hour. So this patient on day 22 suffered a cardiac arrest, unable to achieve ROSC. May his soul rest in peace. So in conclusion, we had this 61-year-old male who had multi-organ dysfunction syndrome, and we see that he also had bone marrow suppression. Thank you for listening. Any questions?
Thank you very much for this thorough case, Dr. Melissa. Sadly, the ending doesn't, excite, given all the work that was done for the session of about 3 weeks. So questions on the chat are welcome at this point. I'll start with just a small appreciation from Dr. Patience of the patient's case, of the unit for all the investigative capacity. This was quite a lot of work by the team. My one question I have on the chat is if the patient, when the tracker spirit was taken off and grew stenotrophomonas multifila. If there was consistent evidence of pulmonary infection, or it was just a finding on investigation. And then the second one is when the cardiac arrest happened, what was thought to be the mechanism behind it, and whether CPR was performed. Over to you, Dr. Melissa.
Okay, thank you, Dr. Erasmus. When the tracheoaspirate was in view of taking off the tracheoaspirate is because he notably had secretions, and they were suspecting a pulmonary infection. And yes, CPR was done because with the conferences that happened over time, the family continued to choose to have the medical team do everything in their capacity. So end of life wasn't really consented for. Stroke DNR wasn't consented for. Yes, so CPR was done.
Yeah, it's quite an interesting one for sure. And I definitely sympathize with the dilemma the clinician has in terms of dealing with a patient of this category whose requirements are high, the future is grim, and it seems not to be responding to the definitive treatment for the underlying malignancy, as well as the thrombocytopenia. Did you get an idea of what the cause of the cardiac arrest was? Would he bleed massively or something? What exactly caused the cardiac arrest?
I didn't get a clear cause, but it could have been anything ranging from PE, given that he had a DVT, and also could have been the hypotension, because he was on high requirement of vasopressors. Yes, so it wasn't really clear what caused the cardiac arrest.
All right, and relevant to today's theme, how did the underwater seal drain perform? Did it reach a point where it was no longer draining? And was it ever removed? He died with it?
He died with it. It was continuous till death.
All right. Thank you. So I'm going to give an opportunity for anyone to unmute and ask a question before we invite the next speaker. Dr. Melissa, you can retire your slides, please. Thank you. Any questions from the chat? All right. So without any further ado, I guess I would like to move the next speaker of the day. So Dr. Jimmy Atiera is a third-year resident in emergency medicine at Mackay University College of Health Sciences. He's going to take us through a diagnostic approach to pleural diseases, and hopefully we can relate with the work that was done on this particular case, and see what was done and what wasn't done for the patient. And then we shall have a discussion. So over to you, Dr. Atiera. Kindly project your slides.
Thank you, Dr. Erasmus, and thank you for the opportunity to present. Someone kindly confirm to me that my slides are visible.
Yes, they are visible, not yet in PowerPoint in slideshow mode, and you're very audible. Thank you. Proceed.
All right. Yeah, thank you. Good evening to you all. I think I've already been introduced, so I'm just going to go ahead and present what I have to present to us today. Thank you, Dr. Melissa. I think that was quite a comprehensive case presentation of that patient. Yeah, I agree with the person who commented that actually that patient has had quite, it was investigated intensively. Yeah, so I'm going to take us through the diagnostic approach to pleural diseases, and particularly I'm going to be focusing on clinical and laboratory investigation. Then someone else will take on the remaining part of the investigation. I have nothing to declare of this talk. So just a basic of the anatomy of the pleura. We know that the pleura, we have two pleura. We have the visceral pleura that outlines the lungs, and then we have the parietal pleura that is stuck. Let me just get my pointer so I could, yeah. So we have the visceral pleura that is the covering just on top of the lungs. And then we have the parietal pleura that outlines the chest cavity. And these two pleurae form a potential space that we call the pleural cavity. It's a potential space because usually you're not going to be able to clearly really point to the space that is formed between the visceral and the parietal pleura. But the importance of that particular space is that it allows for it allows for fluid that is quite important in ensuring that there's effortless sliding between the parietal pleura and the visceral content of. All right, yeah. If there is any challenge, with the pleural cavity, and then you are bound to have a challenge, or patient is going to present with certain symptoms that actually signals that there is a challenge with the pleural cavity. And particularly today, we're going to be paying attention to that. So a large portion of my talk is going to be because that's one of the most common pleural disease that most of the patients are going to be coming with. Yeah, I've been mentioning that within the
Dr. Atira, sorry to interrupt.
pleural cavity is the pleural fluid. It's usually produced in at an amount of fluid. And
Dr. Jimmy, your network is not exactly very clear.
Am I audible?
Yeah, your network is a bit unstable. I don't know if it's a way to just find a stable location. Right, so Dr. Jimmy has just dropped off. Let's give him a few seconds to rejoin. His network connectivity has been poor. All right, so but the chat is open for your submissions and inquiries. We shall have him handle them at the end of the talk.
Internet connection. I hope this will be much better. I've just changed the server. I hope you can hear me now.
Yes, we can hear you now. That's good. Let's proceed. And
sorry about. I don't know at what point all right.
It seems like
okay.
you just explained to us about the fluid production and like.
All right. Yes. So basically, I was saying that the pleural cavity is a potential space that is formed by the parietal and the visceral pleura, and it contains the pleural fluid that basically helps to lubricate the visceral and the parietal pleura so that there is effortless sliding between the visceral and the parietal pleura during normal tidal breathing. And usually within the pleural space, we have up to about 18 mils of pleural fluid. Usually, a normal person is produced at a rate of 0.26. The volume is usually about 0.26 mils per kilogram. So if you are dealing with a 70 kilogram man, you expect to find about 18 mils of pleural fluid within the pleural cavity. Just to take us through the physiology of because the physiology will lead us to the pathophysiology. Just a brief, I'm talking about diagnosis, I'm not going to dwell so much on this. But the pleural fluid, I put my thing on presenter mode. Yeah, so pleural fluid is produced basically by the parietal pleura that has the that embeds the pleural capillaries, and these capillaries have they're basically interplay between the hydrostatic pressure. Those two pressures help to keep the balance and help to keep normal amount of pleural fluid, in that there is not so much and there is not too little within the pleural cavity. And the hydrostatic pressure, we know that is the pressure that's exerted against the endothelium, and usually tends to want to force plasma of fluid out of the blood vessel into the extravascular space. And then the oncotic pressure is the pressure that is created by the proteins, especially albumin, and for it tends to keep the fluid within the intravascular space. So anything that's going to interfere with the two pressures will cause us a pathology within the pleural cavity. Not to forget that the pleural cavity is produced, the pleural fluid, is produced by the parietal pleura, and its absorption is also via the parietal pleura that has the openings of the lymphatics, what we call the stoma, that drains this pleural fluid. And it is stated that there's maximum fluid production at the apex of the heart, and then there's also maximum fluid production at the base, at the base of the lungs. So, and these two, absorption versus production, creates the balance that helps to maintain a normal volume of pleural fluid within the pleural cavity. Also to mention is that usually the absorption exceeds the production. In fact, it's actually stated that the absorption has a factor of 20, like 20 times. The absorption is 20 times the production, so that there is not accumulation of pleural fluid, because we know that within the pleural cavity, there is supposed to be that negative pressure of -5 that allows for lung recoil during tidal breathing. So when we're talking about normal pleural fluid, it's supposed to have the same content of glucose like plasma, because this fluid is basically filtered from blood. So it's basically really plasma. The content of glucose should be the same. We're going to know that the fluid is exudative or transudative. And by transudative, we mean that the fluid is having low protein content. And then by exudative, we mean that the fluid is having high protein content. Just to make mention of some of the conditions that you're most likely going to be encountering when it comes to pleural diseases, we have what we call the pleural C. That basically means inflammation of the pleura. So the mesothelium or mesothelial cells are actually inflamed, and that in the long run will affect the quantity of the pleural fluid within the pleural cavity. And then you're most likely going to encounter pleural effusion, like I made mention earlier. Then pneumothorax, which basically means accumulation of air within the pleural cavity. And then you could also get a hemothorax, like in the case of trauma. You could get empyema in the case of infectious process that's ongoing. And then you could also get pleural tumors, or like, for example, the most common in that case is mesotheliomas. But we know that so many tumors actually metastasize within to the lungs. and that metastasis could spill over to the pleura. The common symptoms that patients are going to be presenting with that could indicate to you that this could be a pleural disease that we are dealing with. Could be difficult in breathing, but of course this is very non-specific because any lung pathology will cause breathing, and also any cardiac pathology could actually present as difficult in breathing. But the one that could actually make you to begin thinking about pleural disease is a pleuritic chest pain during tidal breathing. So when a patient comes complaining of a pleuritic chest pain, then you want to begin thinking that they could actually be having a pleural disease ongoing. Sorry. And then, of course, non-productive cough fever, if it's because of infectious process, could also be one of those leading symptoms that the patients are going to be presenting with. So how to approach the clinical assessment of this patient? Number one is that you're going to just look at the shape of the chest wall. Of course, in our examination, we usually follow the observation. You inspect, palpate, percuss, and auscultate. That is usually the trend that we tend to follow every time we are examining a patient in order to identify what pathology the patient is having. So, for example, if a patient is having a massive pleural effusion, there's going to be a noticeable abnormality with the shape of the chest. If it's asymmetrical, then you're thinking there must be a potential pathology within this chest. And if that is so, that could be, and if it's symmetrical, then you're less likely to think about things like pleural effusion that could actually derange the shape of the chest. And step two, you want to palpate if in case you're seeing anything, or maybe palpate to see if you're able to identify or elicit any tenderness that could make you begin thinking about, that could make you rule out potential pleural condition. But then dullness and percussion would suggest that there is fluid within that chest. And where is it going to be? Most likely within the pleural cavity. And if it is, then you also assess the breathing. If there's diminished breath sound, then you're thinking about most likely there could be a massive pleural effusion that is diminishing your ability to auscultate the breath sounds. And then you could also go ahead to assess for vocal resonance, that this would help you to identify lung pathology rather than a pleural pathology. But of course, we know that lung pathology oftentimes spills over to also affect the pleura. Okay, so we progress to a diagnostic approach, and I've chosen to use this flow diagram to just walk us through what you could do if a patient comes to you and you have examined and you think that a patient could potentially be having pleural effusion. So one of the things the first step that you are going to take is to do thoracocentesis. And in this thoracocentesis, it could either be diagnostic or it could be therapeutic, depending on the symptoms that the patient is presenting with. But for this case, we are talking about to think about analyzing the fluid to decide on whether it is a transudate or an exudate. And the simplest investigation that you are going to most likely do after you've taken a tap is going to be the Light's criteria. Light criteria has been an old way of making a decision on whether this is a transudate that I'm dealing with or an exudate that I'm dealing with, and basically it looks at 3 parameters. So it compares the amount of proteins that is within the pleural fluid with what is within the within serum. So so you get the ratio of proteins within the pleural fluid to serum, and if it's greater than 5, then you want to think that this might be an exudate that you're dealing with. And then also look at the LDH. If the pleural LDH to serum LDH is greater than 0.6, that could also speak to an exudate rather than a transudate. And then if the pleural fluid LDH is they used to talk about 200 units per liter, but a lot of debates has gone on, and they are trying to move away from just quoting a figure and comparing with what is expected to be normal. So now we are talking about if the LDH is 2/3 the upper normal limit, and then that could speak more to an exudate rather than a transudate. So that is the basic step that we take to decide. So if it's a transudate, most times transudate tends to be secondary pathologies. So they are not really pathologies of the pleural as per se. So you're going to have things like heart failure. You're going to have things like liver disease. If the liver is cirrhosed, if you, that creates a buildup of fluid within the vasculature and increases the hydrostatic pressure. And eventually you have extravasation of fluids from the intravascular space into the extravascular space. And one of those extravascular space that the fluid is most likely going to accumulate in is going to be the pleural cavity. And then also kidney disease, as you know, like for, the case in point for this particular patient that has been presented to us, actually had a kidney disease that could potentially, could have potentially caused the pleural effusion that he ended up with. But also if the result is of exudative picture, then you're going to further go on and test, because so many conditions cause an exudative picture, including primary pleural conditions. So what are some of those tests that you could consider to do? Maybe before I could progress to that, there's been a lot of debates regarding the diagnostic accuracy of Light's criteria. Because for it to say only any of the parameters, for long as it's positive, then we say that patient is actually having an exudate or exudative fluid. And that has made so many patients usually to be diagnosed to be having exudative pleural effusion, and yet it might actually not be true. So there are some other tests that have that people think is superior to Light's criteria that people are now using. Others are going on to use the amount of the amount of albumin that is in the pleural fluid. Others have gone on to use glucose versus glucose with pH. So one that has shown consistency, but also has been some people have also debated it, is comparing the amount of glucose in the pleural fluid with what is within the plasma or serum. And yeah, they say there has also been discordancy when you're having a decrease in glucose and a decrease in the pH, because that's what should speak to an exudative picture. And if there is discordancy, then again it creates a debate: is it really truly an exudative picture, or we are missing out something? And then the other thing that we could do is to take off that pleural effusion, take off that pleural effusion and do cytology. And we're able to see, because we expect that the white blood cells in pleural fluid should be less than 1,000. And especially when the cells line that we are more interested in is the polymorphonuclear cells. If they're increased, then that speaks to process that is ongoing. And then the other thing is also just looking at the differential counts of the different cell lines, the polymorphonuclear cells like the neutrophils versus the lymphocytes. Yeah, that could also help us to know. For example, if you're seeing a lot of lymphocytes within your pleural fluid, you're thinking more of TB rather than a bacterial pathology. And then if you are thinking of a bacterial disease, then you're going to see more of polymorphonuclear cells rather than TB, things like that. The other test, I think that also Melissa made mention of when she was presenting the case that we're discussing today, was ADA, adenosine deaminase levels. And this is an enzyme that basically gets elevated in TB. If a patient is having TB, then they are going to be having elevated ADA levels. And usually we talk about the normal level to be less than 40 units per liter. If it's more than 40, then we are thinking that this patient could actually be having an ongoing TB. picture. And then, of course, if we are thinking about an infectious process ongoing, then we also want to want to interest ourselves in what microorganisms or what bacteria exactly are we dealing with. So culture is something that we can also consider so that we can guide our therapeutics that we want to choose for this patient. Yeah, so GeneXpert as well, but GeneXpert of pleural fluid has proven to be very, is proven to be not very reliable. So it's not very commonly done. I think I've talked through. Then, of course, if you are thinking about low levels of glucose in comparison to, together with low levels of, together with acidosis in the pleural, a picture of low pH, then you're thinking about infection malignancy as well. Could be one of the pathologies that you would want to consider. And then amylase speaks to things like pancreatitis or pancreatic pleural effusion. Malignancy could also raise the levels. Esophageal rupture could raise the level. And then if you could also have, you could also do the hematocrit in this case, and if the pleural fluid hematocrit versus the blood hematocrit is greater than 50%, and then you want to consider things like aortic dissection, pulmonary embolism, malignancy, bleeding disorder, or trauma. So those are also some of the things that you could do. And if all these tests still cannot help you to make a conclusion of what is going on with the patient, and then now you want to maybe consider going for imaging, and where you're going to consider doing like CTPA in case you are thinking about a possible pulmonary embolism, then CT scan if you're thinking about maybe an ongoing malignant process, then things like echo just to rule out heart failure. Pleural biopsy would help you to make a diagnosis of primary pleural conditions. For example, mesothelioma could be one of the things that you could get with taking off a sample. And there are different techniques that you could use to take off the sample, which I think we are not going to labor so much on them. When it comes to imaging, which I think someone else is going to be talking about, I'm just making mention of them. One of those that we have at hand that can come in very handy in deciding on whether you have, first of all, whether a patient is having a pleural effusion or not, or is having a pleural pathology that you're able to see. You actually have, we now have a point of care ultrasound scan that is taking shape and is changing a lot of care for our patients and improving care for our patients. So take that probe and just touch into that chest and be able to see, is there pleural effusion or not? And if there's pleural effusion, then you can also still decide on whether it's exudative or transudative. We've heard of the plankton sign. We've also heard of the hematocrit sign that helps us to know whether this is exudative or transudative. And then you can also be able to actually tell the volume that you have that can help you to decide on whether this patient needs therapeutic thoracocentesis or not. And then chest radiography, which I've already made mention of. Chest X-ray is really very available to us. I think has been traditionally used from time immemorial. But sometimes the process of attaining chest radiograph is not as easy as the process of attaining point of care ultrasound scan. So I want to encourage us to actually utilize the probe to be able to make diagnosis of some of these pleural conditions that we could have. Chest CT scan, like I've just said, could be your run too as well. So yeah, thank you. I think I'm going to stop here. I will welcome any question that anyone has.
Excellent. Thank you so much, Dr. Jimmy. That was quite a quick one and a broad one as well. So I believe people have caught up a lot on the diagnostics, at least clinical and laboratory diagnostics. So over to you guys. Any questions? Okay, so the question, comment on the accuracy of focus versus chest X-ray versus CT. May I reserve that question for the next talk, which is going to handle imaging diagnostics for today. Any other questions? All right, if you don't have questions, I have questions, and these ones will go randomly to people in the audience, and so I'll pick you guys, and good luck. Yeah, so Anna Merida Kaguna. which of the following clinical signs is most predictive of a pleural effusion? Most sensitive, sorry, for pleural effusion. Dr. Anna Kaguna. Okay. Does anyone want to attempt this? You can just unmute and shoot it down, and we'll move on.
I think if we are talking about, oh, okay.
I'd go for the dullness to percussion.
Okay, dullness to percussion. Yes, Jimmy, you're the expert here.
Yeah, I agree with Anna. I was also going for that.
Okay, I will not give the answers yet on this or my response to it. But yes, so let's move on to the next one. The next question is, which of the following is most specific for pleural effusion? So it turns out actually that there have been studies looking at the sensitivity and specificity of clinical signs in predicting presence of this condition. So which of these would predict, would be more specific of a pleural effusion? Ignatius, Sembuya? Don't be shy. Which of pleural friction rub? Yes?
C. C.
All right, diminished breath sound. So yeah, Jimmy, what do you think? You agree with him?
Yes, I think I made mention of that in my presentation. I would go with that as well.
Bird sounds, no.
What's that? Okay, so Walithandia.
But
Walithandia goes with A, pleural friction rub. And then Asimire goes with dullness to percussion. Excellent, excellent. Okay. All right, and Sophie also goes with A. So maybe you guys can just throw in your votes for this in the next 1 minute on the chat. I'm happy to go with you in the chat. Okay. Cesar says reduced vocal resonance. So I see so far each one of you has 25% chance of getting it right. Since I want just one. So 25 is good. You know. But there's only one correct answer here for the most specific. Okay, Simira has chosen C. Gola's second, reduced vocal resonance. Okay, so just so we don't get hung up here, I will now throw in the final one for this particular segment. Which of the following is most predictive fusion? Most predictive. So you can just share your answers on the chat. Okay. So no one is throwing in answers yet, so I might have to pick out someone. So Bertha, you want to take a shot at this one? Bertha Catherine? Which of the following is most predictive of complicated pleural effusion? Is the friction rub? Is it a pH of less than 7.2? An effusion more than a quarter of the hemithorax? Is it the presence of a pneumothorax? It's the presence of pneumonia. All right, so I see so far people have voted are all choosing a pH. All right. Okay, so you have just 10 more seconds to throw in your answers, then I will proceed. Good. So I will just move on. You can continue throwing in answers. I know you've seen the question already, but just in addition to our talk on diagnostics so far, I would like to invite Dr. Fiona who is a collaborating specialist from radiology. Dr. Fiona is a third-year radiology resident who will be taking us through the imaging of pleural diseases. Doctor, over to you. Share your slides.
Hey, thank you very much, Dr. Erasmus, for the opportunity to discuss with you guys today. Just to confirm that you can hear me very well and you're able to see my slides.
Yes, we can.
Thank you very much. So I am going to just briefly take us through the imaging of the pleural space. So the brief outline of my talk is to look at the anatomy of the pleura. The previous presenter ably described the gross anatomy. I think we'll look through the imaging modalities that are used when we're imaging pleural diseases and describe some of the imaging features we'll see in some of the common conditions that we usually diagnose that come from the pleural space. So I'll skip that slide, and looking at the imaging modalities, commonly in our setting, you're going to find most of our diagnosis of pleural diseases usually starts from the chest X-ray for very many reasons. One, it's one of the investigations that are most commonly available and they're very affordable. So you'll find that for most patients, their chest imaging usually starts from the chest X-ray. And as we're going to see, most common views will look at the AP, lateral, and decubitors, and what type of view you use usually depends really on the suspicion or exactly what you're trying to look for. Then CT comes in second, with or without contrast, also depends on usually what you're suspecting clinically. And then we can use ultrasound and MRI with or without contrast, as we're going to see. So radiologically, especially on the chest X-ray, we usually don't see the pleura, especially the parietal pleura. We don't completely visualize it, but then the visceral pleura, there's specific areas where you're going to see the visceral pleura because, as Dr. Jimmy mentioned, it surrounds the lung, but then you have all these invaginations like the fissures that divide the lung into different lobes, and the fissures are made of the visceral pleura. So sometimes, depending on the quality of your image, you can actually, you're able to see the fissures. For example, in this image, it's a collimated image of the chest X-ray, and we're able to see the horizontal fissure in this lung, in the right lung, and then the visceral pleura, as also Dr. Jimmy mentioned, they kind of join at the point of the mediastinum, and then they form what we call junctional lines. So many times we look for these junctional lines also when you're suspecting pleural pathology, and it's not very obvious. So the pleura meets both posteriorly and anteriorly, and the posterior junctional line, you usually see it more superior as compared to the anterior junctional line, which is usually more inferior to the posterior junctional line. And these are just the points where the pleura meets in the mediastinum. So those are the main places where you probably see the pleura on your chest radiograph, but normally these are not things that we can routinely visualize in the chest X-ray. A lot also depends on the quality of your radiograph, really. And then also when we're describing pleural pathology, usually you want to talk about the portion or the part of the pleura that is affected. So this is the cervical portion of the pleura, which surrounds the apex of the lung. Then the costal portion is the one that is around the cage. And then you have the diaphragmatic portion, which is adherent to the diaphragm. And then you have the mediastinal portion. So sometimes you may have disease that is affecting maybe the mediastinal portion or the cervical portion or the costal portion, as we're going to see. Then another place that we always look at when we're assessing the pleural disease are the costophrenic angles or the costophrenic recesses. And in your radiographs, you want to really see very clear outline of your costophrenic angles, and occasionally also the cardiophrenic angles, but most times the emphasis is on the costophrenic angles, both on your AP or your erect radiographs and the lateral radiographs as well. So looking at pleural effusion, we'll also not go into the details of this, as Dr. Jimmy already explained, but sometimes, as we have seen, making a diagnosis whether your effusion is a transudate or exudate most times ends up in cytological analysis, but many times your imaging can also help to infer what type of effusion you're dealing with. So there are some radiological characteristics that can help you categorize your effusion to be a transudate or an exudate. Then when you're looking at your radiographs, also there are certain volumes that are going to be seen radiologically. For example, if you're looking at an AP or a PA radiograph, and you don't have effusion, which is more than 150 mL, you may not be able to see it on the radiograph. There's literature that actually puts the value up to 250. I just went with the lowest limit. And then your lateral chest radiographs will see fluid of up to 40 mL. So the lateral is actually more sensitive than your AP or PA erect radiographs. The decubitus is the most sensitive view of the chest radiographs, and it can see about 5 to 10 mL of pleural effusion. And then supine is the least sensitive. You need almost twice the amount of fluid in the AP for you to be able to see in a supine radiograph. So what are the features you look for in your chest radiograph? An erect chest, this is an erect PA or an AP. As we say, look for your costophrenic angles, they may be blunted. You look at your cardiophrenic angles, look for fluid within the fissures. As we mentioned, that is the only extension of the pleura into the lung parenchyma. Then eventually we'll start looking at things like the meniscal sign, which we're going to explain, and very large volumes of effusions are going to result into things like mediastinal shifts, as we're going to see. So we're going to look at some radiographs. It's case-based, so some of these cases are for patients who we saw here at the department, but some of them are borrowed from Radiopedia. So this first set of images, I'm not going to describe the entire X-ray like how we usually do. I mean, we're trying to focus on the pleural spaces. So I would look at my costophrenic angles if I was looking for an effusion. And for this patient, I can see a very nice, sharp costophrenic angle on both sides. The cardiophrenic angles appear okay. I cannot even see the fissures, which is the common thing. Not with all the radiographs, you see the fissures. And if you don't see it, most times it's a good thing. And many times when they're very visible, then you're worried of pathology. And then on my lateral radiograph, I'm seeing my costophrenic angles, very nice and sharp. So this is what a normal chest radiograph would look like. So this first case, we have a 60-year-old female who came with history of difficulty in breathing. And what we're looking at erect frontal radiographs. And if you look at the costophrenic angles bilaterally, we're not seeing the very nice sharp curve that we expect to see here. So this costophrenic angle is actually a bit blunted. Same on this side. We're not seeing the very nice sharp edge that we expect to see here, although the cardiophrenic angles still appear okay. So we went ahead and did a lateral radiograph for this patient, and then the costophrenic angles on the lateral chest X-ray, you will expect to see them down here, but the entire area is actually filled with fluid, or we're seeing this homogeneous opacity. So the AP or the frontal radiographs have a tendency of underestimating just how much fluid is in that chest, because the fluid is dependent and it's going to just go down into the recesses. If it's not much, you may not see it, or you may say, okay, this is a very mild effusion. And then you do your lateral chest X-ray and you actually see that this is significant volume, or this is a lot of fluid in the patient's lungs. I mean, in the pleural space. So it's always, the point of this really patient or the case was, many times if you're clinically suspecting and you do your frontal radiograph and you're not seeing anything, it doesn't hurt to get a second view. Do a lateral or do a decubitus, which demonstrate much smaller volumes of fluid, and you can actually able to sometimes demonstrate the pleural effusion, especially if you have a very high index of suspicion. So the second case, we have a 65-year-old male who came with a short history of progressive shortness of breath. And on the right side, we're seeing this homogeneous opacity. There are no air bronchograms. So I know for sure that this is not pathology in the lung parenchyma. But then when you look at the lateral edge of this opacity, you see it higher than it goes to the medial side. And this is what we call a meniscus sign. So the meniscus sign, one, helps you to make a diagnosis of effusion. And then secondly, it almost gives you a very clear indication that you're mostly dealing with the transudate, because this means this is it's a simple fluid, and it's actually able to rise just along the walls of the lungs. So meniscus sign usually is indicative of a transudative or a very simple fluid, and it also just can give you a very clear indication that this is fluid as opposed to, let me say, mass, especially if that is something that you're suspecting. The second patient here, 65-year-old female who presented with shortness of breath and on examination had dullness of percussion, dullness to percussion over left thoracic cavity. And then we're still seeing this homogeneous opacity. We're seeing this very nice, clear meniscus sign. The fluid on the lateral wall or the lateral edge of the lung goes much higher, and then it almost just slants as you come medially. And that's what we describe as a meniscus sign. And then also to note here is there's a clear mediastinal shift. Our trachea is to the right side. The heart border is to the right side. So simple fluid, but we're having mediastinal shift. So it gives us an indication of just how much fluid or the volume of fluid that we're seeing in the left side of that chest. The next case, an 80-year-old male with history of confusion and hallucinations has diagnosed and admitted with metabolic encephalopathy. Current complaints are chest pain and shortness of breath. He's the diabetic, hypertensive, had a cabbage done 5 years ago, has a pacemaker in situ, essential tremors, and also has Parkinson's disease. So this is a very sick patient. Now I'm going to, it's not a rule of thumb, but it's something that we use to, in quotes, cheat. Most times when you see a patient who's very sick, like this one, or you look at your chest radiograph, you're seeing ECG, you're seeing tubes everywhere. It's very, very likely that that is a very sick patient, and you're almost 90% certain that that patient, that's not an erect radiograph. And that is very important. But you might find a very enthusiastic radiographer who will lift that patient off their wheelchair and try and make them stand to get the radiograph, but that rarely happens. So a very sick patient, most times you're almost sure that I'm dealing with an AP radiograph, and many times that patient is bedridden, and sometimes you're actually dealing with a portable radiograph. So as you're looking at that radiograph, one thing you need to keep at the back of your mind, did they sit this patient up? So is it an erect radiograph? Was this patient lying? And the patient like this who has a lot of cardiac issues, we know that they're very uncomfortable. So it's very likely that positioned at 45 degrees on that bed when the chest radiograph was done. Or is my patient actually lying supine on the bed and my X-ray tube was just directly above the patient? So those are questions you have to ask yourself before you look at that radiograph, because it can easily confuse you. For example, now looking at this X-ray, there are other pathologies we're obviously seeing. This sternotomy wires, probably from when they were doing the cabbage, the pacemaker is in situ. But then you see the costophrenic angles, blunted bilaterally. But on the left side, there's something that is very interesting. You can see this opacity. It's like layering. It keeps reducing as you go towards the apex of the lung. So by the time you reach here, you're almost seeing the normal lucency that you would expect in a normal lung. But then at this point, you're seeing like a layering opacity as you're going towards the costophrenic recesses. And this is a very clear example of what we call layering effusion. So, and then when you look at the lateral, this is, again, it's not a true lateral, and you can tell that you can see exactly where this fluid is layered. And this is a patient who is lying at 45 degrees. And this is very important because you can easily see what is here. It's not very opaque, like how you would see an opacity in a fluid. And you may think maybe it's an infiltrative process going on, or maybe the patient has a pulmonary edema, yet it's just layering effusion, and it's appearing like levels of haziness as it's going upwards. So this was just to explain what dependent fluid and patient position looks like. Because with simple fluid, it's going to move depending on how the patient is lying. So this is a patient who is in semi-upright position. You'll see that layering haziness increasing from the costophrenic angles going superiorly. And the next radiograph is for a patient who is actually completely supine. So that fluid will just layer the entire back. So that entire lung will appear hazy. And if you don't have very good clear history, this, and maybe my request as a patient being managed for heart failure, my head is already thinking, okay, this is just pulmonary edema. And yet, if I had an idea that this was a supine radiograph, my first thing I could think of a layering effusion. So patient position with simple effusion is very important because that fluid is going to move based on how you position your patient. So it's always important to know, like, was my radiograph AP or PA? If it was AP, was it an erect? Was it a semi-upright, or was it a supine radiograph? And then also another thing is, you look at this costophrenic angle, you're like, okay, maybe I have 200 or 300 mils of fluid here. It's not too bad, but yet the fluid is actually layered. And when you straighten this patient, it's a lot more fluid than what is expected. So this same patient was changed into an upright position. They gave him a few minutes, and then they went ahead and repeated the radiograph. And you can see how the fluid just the fluid just goes back into its dependent position. And now we're seeing that there's actually a lot more fluid than what we thought was here. So patient position, when we're looking at effusions, is very important. So if you're still not sure that you're dealing with an effusion, get a decubitus, lie the patient down. So lie the patient to the side where you think the effusion is. So if you think the effusion is on the right side, do a right lateral decubitus. If it's on the left side, you do a left lateral decubitus, and that fluid is going to layer just on the side where the patient lies. And this can layer in very little fluid, as little as 10 mils, and you're able to make your diagnosis of a pleural effusion. And if you're still not sure or you're still not convinced, then you can go ahead and do a CT. So again, CT, our patient enters the machine when they are supine. So that fluid is going to go posteriorly at the back. So you will just, on your CT, on the axios, you see this, most times isodense, but then it layers the entire back because your patient is lying supine. So if I had a scrollable image and I'm scrolling all the way from the apex to the level of the diaphragm, you will see fluid that entire level. And CT will show you effusion as little as 5 mils. So it is the most sensitive when you're looking for a pleural effusion. And this is what it will appear like on your coronal chest CTs. So I just put this image because I wanted to demonstrate how the fluid layers when you lie the patient down. So it really just goes to the patient's back. This patient, I remember, had, I think, heart failure. Then on the lung window had this interlobular septal thickening, which was suggestive of pulmonary edema, had an ETT. So this patient had a heart failure with pulmonary edema and then resultant, and also had pleural effusion. So next case, we have a patient with long-standing history of chest pain and fevers. So on the left side, we're seeing this homogeneous opacity. It's planting the postophrenic angles, but then we have this other, it's like a mass, more oval shaped, and it's along the pleural wall. So your first thought is, am I dealing with a mass? Is this, could this just be a pleural mass? But then when you look at it, the density is not, it's not as bright as a mass would appear, because a mass is more dense than fluid. Then you go ahead and do a lateral chest X-ray, and you're seeing this well-defined, I would still call it an opacity, but it's not as dense as a mass. So this was a case of loculated effusion. And this patient went ahead and did a chest CT, and you can see this fluid is all, because now for a patient who was lying down, and if this was just a simple effusion, you'll expect all this fluid to just fall here because it will go into the most dependent area. But then you see the fluid just layering the entire lining, almost the entire pleural space. And this is loculated effusion. And it's at this point when you're starting to think exudative effusion, because a simple fluid will not normally give you a loculated effusion. So, and then another thing that will make you think of an effusion more in this case is because you already have a clear effusion, and then you just have this effusion that is connected to this other loculated effusion. So your first thought would be a fluid, but the most convincing thing is the density. A mass is not this dense. A mass is much denser than what you're seeing there. Then case 7, a 30-year-old male with history of fever and chest pain for 7 days. This was a case that we saw at the department. And he had this well-defined opacity, almost looks like the Hampton's hump that we see in pulmonary embolism. But then look at the postophrenic angle, they are completely obliterated. You have no air bronchograms in this mass. It forms a very obtuse angle with the chest wall. So I know that this is coming from my pleura or the pleural space. And the density is also not as dense as a mass. So this was also, when we went ahead and did a CT, this turned out to be an inoculated effusion. So we always pay attention to those. Then case 8 was to demonstrate subpulmonic effusions. This one, I mentioned them because I would say 99% of the times we always miss subpulmonic effusions because they're very hard to pick on the chest radiographs. And this is effusion that is just right below the lung. So if it is on the left side, it may be a bit easier because most times you look at where your diaphragm is and where your gastric bubble is. That distance between the diaphragm and the gastric bubble should not be more than 1 centimeter. So when it's greater than 1 centimeter, you have to start thinking there's something in between my diaphragm and the gastric bubble, and most of the times it's actually fluid. But on the right-hand side, it's a bit more difficult to tell. We usually use the positioning of our diaphragm. There's something we call a pseudo-diaphragmatic contour. So the diaphragm kind of gives you a hump, but that hump is more lateral, and you see it's sliding medially And when you see something like that, it's always indicative. Actually, it's very, very specific for subpulmonic effusions on the right side. So that's simple. And if you're still not sure, if you're never sure, and you're suspecting a simple effusion, lie the patient down, do a decubitus. That fluid is going to go to the patient's side, and you can be able to see flaring at that point. But it's most of the time, even for radiologists, we always miss the subpulmonic effusions, and then you're wondering why the patient is still having chest pain and having trouble breathing, and yet we are not just picking the effusion. Then another thing to mention is diagnosing pleural effusion in the setting of ascites. Sometimes you can get a patient and you only have an abdominal CT. And usually CTs will give you a little bit of the lung bases, not too much. But then the fluid that the ascites may not be explaining the patient's symptoms. They are severely dyspneic, and and the amount of fluid in the abdomen is not explaining what you're seeing clinically. And sometimes it could just be a pleural effusion. You haven't imaged the chest, but you can pick that effusion from your abdominal CT. And most times we use these 4 signs. We have what you call a diaphragm sign. So diaphragm sign is you see your diaphragm and you see fluid on both sides of the diaphragm. You see fluid in the abdomen, you see fluid in the lungs, which is very easy to tell. But then the bare area sign, usually when you see your liver, the liver is supposed to be adherent to the rib at this point where we're seeing the 2 black arrows. So if you see any fluid between the liver and the ribs at this point, like what we're seeing here, then that simply means you're having fluid in the chest as well, and that fluid is not in the abdomen only. And then the displaced cruise sign, you look at your diaphragmatic cruise. If it's not adhering to the vertebral body nicely, most times there's fluid causing it to be lifted off, and we're probably dealing with a pleural effusion. And then lastly, the interface sign. So the interface sign is this clear interface between the ascitic fluid and the liver. So it usually tells you that there's ascitic fluid. So interface sign, you confirm, for example, in both images A and B, we can clearly tell there's ascites because of this clear interface between the fluid and the liver. But in this case, you have this positive bare area sign and you have a displaced cruise sign telling you that there's actually fluid in the chest as well. And we're not seeing that here, meaning this patient only had ascites, but this patient had both ascites and a PE. So many times when you have your abdominal CTs, it's just critical to look in that area, and you may be able to pick your pleural effusion from there. Then lastly, there's something we call a pleural pseudotumor, which is an effusion that is loculated within your fissures, almost appears like a mass, but it has a very different density. It's less dense than a mass. And if you're still not sure, turn that patient in the decubitus, that fluid will move and you can confirm your infusion. For the ultrasound, the previous presenter mentioned about it. We use a lot of it in point of care ultrasound. You put your probe, you're able to see the fluid between the diaphragm and the lung. Talked about the plankton sign that can help you to differentiate if it's a transudate or an exudate, because when you start seeing loculations, when you're seeing your fluid is not clear anechoic fluid, then you know that that's not a simple effusion. I'm most likely dealing with an exudate. But if you have a clear fluid like what we're seeing in B, then most times that is more a transudate. We also use a lot of ultrasound in interventional radiology procedures. When you're doing thoracocentesis, you put your probe, you see the fluid, you're able to put your tube right where you want it to go. But that presentation will be discussed a lot later. Then for pneumothorax, which is presence of air in the pleural space, on your radiograph, there are specific things that we look for. There's what we call the visceral pleural edge, or a pleural line. And you should not be able to see any lung markings beyond that pleural edge. And then the area is more radiolucent compared to your adjacent lung, and sometimes you may have a completely collapsed lung. So this brings us to case 10 and 11. So you have on the left side, you have this clear pleural line, which is this, I guess, the wall or the lining of your lung, which is your visceral pleura. And beyond that line, you don't see your lung markings continuing. And then and this area is more lucent than the actual lung. So usually that's how you would tell that it's a pneumothorax. Importantly, when you have a collapsed lung, you should be able to pick that from your radiograph, because you want to put in a chest tube quickly so that you can re-expand this lung. Many times the lateral doesn't add much to your diagnosis of a pleural of a pneumothorax, or unless you're looking for something else. This was an interesting case that we discussed. We got this patient was having chest pain, no difficulty in breathing. There was a lot of argument if there was actually a pneumothorax. There were some people who were seeing it. Many of us were not seeing it. And the consensus was to go and do a CT, and it turns out this patient actually had a pneumothorax. And I think it was an interesting case because of how subtle it was on the chest radiograph. Tension pneumothorax, it's a clinical diagnosis. You do not want it to be picked up by your radiologist. But what we're looking at are hyperexpansion of the lungs, the hypertransradiancy. That lung is usually collapsed. We have a depressed diaphragm and the contralateral mediastinal shift. So we have our pleural line is here. So anything beyond here, we're not seeing any lung markings. The entire mediastinum is to the left side, a case of tension pneumothorax, and we can't even see the lung. So the entire right lung is actually collapsed. Same with the case that we're seeing here. So case 15, you have a 50-year-old male who presents with cough. In image, the history is for patient in image A, and my question was, is this a pneumothorax or not? Because I'm seeing a lucency, I'm seeing it being surrounded by an opaque line, but this is not a pneumothorax. A pneumothorax is in the pleural space, so it has to conform to the shape of the lung. So you have to see something that goes like that. It has to actually conform to what the pleural space looks like. So it enters the entire pleural space. So this was actually a case of a bulla, and then it being surrounded by the wall, a thin wall. Another case here, pneumothorax or not, this was also not a case of a pneumothorax. You can see the translucency. It's only in the middle to the upper lung zones, and it has a very nice wall, and this was also a case of a bulla. 80-year-old male recently fell, came in with history of chest pain, and we're seeing this lucency. Again, the question was, is this a pneumothorax or not? So for starters, it wasn't going around, it wasn't following the normal shape of your pleural space. And secondly, if you just look clearly, I can see my lung markings going from here all the way into this lucency. So as long as you can see lung markings in that area, it's also not a pneumothorax. And this was just a case of a skin fold. We stretched the patient, told them to expire, and the skin fold went, and the lungs were actually quite clear. So briefly, talking about pleural thickening or pleural masses, most times it's indicative of an organized or end-stage process, asbestos exposure or pneumothorax or even hemothorax. The previous presenter mentioned about it. Blunting of the cadophrenic angles is usually an incidental finding. When are you most concerned about your pleural thickening? If it's greater than 1 centimeter, it has a specific specificity of up to 94% for malignancy. If it is circumferential and it actually involves the mediastinal surface of pleura, it has a 100% specificity for malignancy. If it is nodular, it has a 94% specificity for malignancy. And then the mediastinal pleural thickening has a specificity of 88% for malignancy. So case 18 was a case of a mesothelioma. Patient had an effusion. You can see the homogeneous opacity obliterating the costal cardiophrenic angles, no broncho vascular markings, but then you look at this irregular thickening of the pleura, and usually it is very circumferential. It forms it goes around the pleura, and it forms something we call a pleural rind. So this is a better image. So it forms around the wall, and then it keeps encasing the lung. So it grows inwards. So it will, if we didn't intervene and you did the CT maybe a couple of months later, you'll find the lesion has extended up to here, and the only part of normal lung you'll be seeing it in the central. So that is the normal pattern of encasement of a mesothelioma. But it presents as pleural thickening, which is usually nodular, extends into the mediastinal pleura as well. And for this patient, he had these very interesting pleural calcifications that we're seeing here, which are everywhere. So there's also the possibility of an asbestos exposure for this patient because of these pleural calcifications and thickenings that are widespread, which were different from the mesothelioma. And this is what it appears like on the CT. Other pleural masses, again, I'm not going to take too much time on this. The previous speaker mentioned pleural metastases are very common. Usually you see nodular thickenings of the pleura. Pleural fibroma is very common. We've seen very many cases of asking tumors, especially in the pediatric population. So you see a very nice ovoid thickening of the pleura, most times biopsy, because it's, and the interesting thing I have seen with the cases of asking tumor that we have seen in the UCI, most times they're actually diagnosed as like an Ewing sarcoma of the foot. And then when you're doing your chest CT to do staging, then you find the primary tumor. And then that's when you realize, okay, this is actually the primary, and what we're having on the leg is a metastatic lesion. Yeah. So these are other masses that we commonly see in the chest. So finally, I want to talk about an empyema, which is when you have pus in the lungs. Most times patient history guides a lot, and on imaging, you find this fluid density with a very thickened pleura, and when you give contrast, that pleura will actually enhance, and it usually gives us something we call a split pleura sign. So your visceral pleura will enhance, the parietal pleura will enhance, and then you have that fluid density right in the middle, and that's what we call a split pleura, and it's almost diagnostic for an empyema. Then sometimes you'll see air fluid levels, especially if you're having flesh-eating bacteria, you may have air fluid levels within your empyema. And then sometimes you also see an abdominal lung parenchyma to show you that, okay, this patient maybe had a pneumonia, then ended up with a parapneumonic effusion that was not attended to, and then we got to an empyema. So, and also history is also usually very suggestive. Maybe one thing to note just before we continue, sometimes it's very difficult when you have a mass like this to tell if this is actually a pleural mass or this is a lung mass. And there are some signs that we look for. One, you want to look for air bronchograms. Air bronchograms are like the course of your bronchi through that lesion. So if you have a homogeneous mass like this, you don't see any air bronchograms in them, it's very likely that it's coming from the pleura. If it had air bronchograms, then most you would think lung. And then also the angle, this mass is usually formed with the chest wall. If the angle is more than 90 degrees, like what you're seeing here, then you're almost certain that this is a pleural mass. But if it's a very acute angle, then you know that that's a lung parenchymal mass. Then we talk about bony destruction. If the lesion is invading the bone, most times that is something that is coming from the pleura, and also the epicenter of the mass can tell you where that lesion is coming from. So yeah, I think that brings me to the end of my presentation. Any questions are welcome. Thank you so much.
Excellent. Thank you very much, Dr. Fiona. I know Dr. Rem will be extremely proud if he was here. Thank you for taking us through quite a beautiful, interpretation of images. And I never get enough of this, and I still keep learning. There's always something the radiologist is hiding from me that I kind of blows my mind every time they say it. And this is quite a beautiful show. I implore and encourage everybody who practices in the acute care setting to just have a week or two sitting with the radiologist just to go through images. You catch a few things that we usually let go on images and just stare at us. Then sometimes you're unfortunate enough to discharge a patient only for them to turn up at another doctor who says, hey, the thing was here all along and you missed it. It's embarrassing. So questions on the chat. We'll start with some of the questions on the chat. So Doc, which of the ultrasound and X-ray and CT is most accurate in diagnosis of pleural processes, especially pleural effusion? That's the first question.
Okay. So when accuracy, if you're to rate, I would put an ultrasound first. Why? Because ultrasound can help you detect as little as 5 mils of an effusion. Secondly, an ultrasound is one modality that's actually going to clearly tell you if you're dealing with a transitive effusion or if you're dealing with an exudate. Because if it's an exudate, you're going to see it won't be a very clear anechoic fluid. And then an ultrasound, for example, what we saw in the pseudotumor, it will be, you put your probe and if you're maybe confused if this is a mass or a fluid, you put your probe and the ultrasound can clearly tell you if you're dealing with a fluid or a mass. But then the disadvantage with ultrasound is that it doesn't see its visibility of the lung. We're still working around that. I think more and more we're starting to realize just how you can use it when you're imaging the lung, but it will just give you information about the fluid and that's it. So you're not going to be able to look at the rest of the lung. So if maybe I was looking at a chest radiograph, I can see my effusion, I can see my mnemonic process, and I'm able to make a more comprehensive diagnosis that this is an effusion and it's secondary to a pneumonia, and this is a parapneumonic effusion. Or I'm seeing masses, this might most likely be a malignant effusion. So it has its advantages, it has its disadvantages, but I would say an ultrasound is actually a quite specific investigation, but it will just give you limited information. That's its disadvantage.
All right, thank you. But
yeah.
Maybe also the other thing is the fact that it's also user dependent, really, and then not the same skill set in picking up a number of these and getting good images, and so basic stuff could be missed on it, and that may reduce its accuracy in picking up things.
Exactly.
Yeah. All right. So because we are doing badly in terms of time, I'd like to just take one more question on the chat, and I'll ask Dr. Fiona to help answer some of the questions on the chat. There's a question from Dr. Setabi that is inquiring as to how the chest X-ray of a hemothorax with subcutaneous emphysema would appear. I don't know if that will need an image. I got some images on my slides that I could share, but maybe you can just give us a description, doctor, before we proceed to the next speaker.
Okay. A hemothorax is, we usually describe it more as an exudative fluid. It actually appears a lot like an empyema on a chest. Okay, in a chest radiograph, you'll probably just see. Sorry, I'm trying to see if I can get to one of the images very quickly.
I shared some images on the side. If you can catch a few things there. These are images from traumatic care.
Okay. So on a chest X-ray, it's very difficult to really tell the type of effusion you're dealing with because all of it will just appear as a homogeneous opacity like this. But a subcutaneous emphysema, you will see lucencies outside your chest wall. So if this is where my chest wall ends, just because this is the subcutaneous part and this is your skin, you will see the lucencies here. And usually it doesn't appear like a very nice smooth lucency. You're seeing lines in between your soft tissue, and it has a very classic appearance. I think an image will better demonstrate it. But it's very easy to tell your subcutaneous emphysema, but it may be very difficult to tell that this effusion is a hemothorax. Sometimes history can, maybe if it's a trauma case, you may suspect that this may be more of a hemothorax, but the fluid will all appear like this. Most times a CT will give you more information on the type of fluid as opposed to the chest X-ray. Yeah.
Excellent. Thank you so much, Dr. Fiona. Kindly go to the chat and help us respond some of the questions arising relevant to your talk. In the meantime, Dr. Cornelius, could you share a poll? Just have one question for the audience, and please keep around. Because today we shall go beyond our usual time. We have quite beautiful serving for you guys coming up. Dr. Cornell, over to you.
Yeah, the poll is launched, has 4 questions, and it'll probably take about 2 or 3 minutes to respond to it. And then we'll probably leave the responses to each of the questions to the mentor of the day. It seems the poll has closed randomly. I'm not sure why. So maybe let me see if I can relaunch it. All right, I have relaunched it for those who had not yet completed. I think only 6% of the audience had completed. Sorry about that. So in case you had made your choices, please just respond to them quickly again and submit them. I don't know why it closed. So
Looks like we are seeing the results instead.
oh, you're seeing the results. Sorry. Let me relaunch. Let me see if it can relaunch the poll. Oh, I don't. Okay, it has been relaunched. Let's give it 2 minutes. I'm going to reduce it to 2 minutes. So those who had responded, please respond again and submit. I don't think you're going to change your answers. And those who had still filling out, let's give you about a minute as well. Okay, so we will close the poll when at least 25% of the audience has responded. We are almost at 25%, so in case you need to submit your answer, do it as quickly as you can. Okay, so we are at 25%, and I'm going to close the poll in a few seconds, in 10 seconds actually. All right, I'll end the poll, and then I'll share the results. Okay, so again, the first question is a 65-year-old presenting with dyspnea and pleural effusion is suspected. What is the most sensitive initial imaging modality to detect pleural effusions? And 100% of those who responded picked lung ultrasound. And then the next one is an image that you're supposed to interpret. And the question here is name the diagnostic sign. And 75% of the audience selected deep sulcus sign. And then third, the third question, the classic chest X-ray finding in a large perfusion, 88% of the audience picked meniscus sign. And then the final question, which CT scan finding is most suggestive of malignant perfusion? And 81% of the audience picked pleural thickening more than 10 millimeters with nodularity. So I will stop sharing and I'll hand this over back to Dr. Erasmus. I think for the sake of time, I will leave the mentor to weigh in on some of these poll questions later. Over to you, Dr.
All right,
Erasmus.
thank you. That is totally agreeable. We shall do this in conclusion. So kindly stay around for some of the responses to some of the questions we shared today. Yes, I know some people might have moved on, but kindly let them know we still have a lot in store for them. So, all right, so we are moving on to the next talk. Dr. Priscilla is an anesthesiologist, recently graduated, my, and she is taking the game to the market now. She is going to take us through the advanced interventions in the restrictive, sorry, this is a wrong. She's going to take us through the approach to management of patients with the pleural diseases. So kindly share your slide, Doctor.
Thank you. Good evening, everyone. I'm going to take us through therapeutic approach to pleural diseases, basically talking about how what we can do when we're faced with patients who come with pleural disease as one of their either main or part of the complications they come with when they come to hospital. So I'll begin by classifying. Pleural disease could be due to primary lesions. This is when you have infections primarily at the site, causing a pleuritic infection, or it could be bacterial, it could be viral, most times superimposed the bacteria. It could be a tumor, like we've seen from the past presenters, the mesotheliomas, primarily from the pleural site. It could be due to trauma, just as you've seen in the many different case scenarios. Or it could also be due to a secondary lesion. This is when you have a spread of infection. Let's say a patient comes in with a pneumonia, then it spreads, or a malignancy that comes from a different site and it finds its way to the pleural space and causing the complication that we usually see. And most of the complications you'll find, there are a number of them, but you'll find that once these have infiltrated the pleural space, you have things like a pneumothorax, you have a hemothorax, a pyothorax where you have the pus and pyema, you have fistulae, for example, the broncho pleural fistulae, or you have a chylothorax if, let's say, you've had trauma if you've had trauma or even a mass, a tumor that will present with lipid-rich like fluid in the pleural space. Melissa? So what we want to consider is, just like most of the case scenarios we have, we want to go through the general principles of management. There's something that's causing the pleural disease. So you want to treat the underlying cause of the disease first and foremost, because that's going to it's going to give you a prognostic sign for this patient. So if you don't treat the underlying cause, then you just keep having recurrence of the pleuritic disease. And most of the goals of therapy is you want to, if it's an infection, you want to do infection control. We'll see later on it will involve antibiotics, it will involve use of the DNA, some intrapleuritic injections that we usually use. You want to remove the fluid that has been accumulating in that area using, thoracentesis or a chest tube. And you want to promote lung re-expansion. Remember, because of the different pleuritic disease states, then you're going to have collapse of alveoli due to pressure variance, and this will lead to failure it will lead to respiratory distress syndrome, which will affect your goals. I can't see the screen. Melissa? Maybe she has logged out. But yeah, so you also want to manage symptoms. For example, if the patient will most likely be in pain. If it's an infectious process or an inflammatory process, they will have fevers. And sorry, Melissa is re-logging in. My laptop has issues, so she was helping me project, but nonetheless, we'll continue. So you want to manage symptoms like pain, fevers, any other symptoms that the patient presents with, and this is when you use adjuncts like analgesics, antipyretics, as you manage these patients for their comfort, but also as you treat the underlying cause. Now, a paper under JAMA article, it was talking about it was a systematic review that looked at a number of papers that were looking at thoracentesis as how it's done, by which caliber of people, and what complications can come about when you're doing thoracentesis. And we'll look at it as a mode of management as we are managing pleural effusion. So are we managing an exudative state or a transudative state? We have looked out, I'll run through this because I think Dr. Tierra has mentioned to us most of these. Normal pH of the pleural effusion is usually about 7.6, and when you have below 7.2, then this indicates a severe state of the pleural effusion, and we'll need drainage. Fast forward to the normal protein values, we have different normal criteria, and this is important because as you do your management, you want to know what the norm is so that when you have the results, you're able to interpret and manage this patient depending on whether it's an exudative or a transudative state. So like a number of criteria have been used, including the light criteria that was mentioned earlier on. It's been used by a number of people, but people are moving on to using cholesterol as one of the things. So this paper basically looked at if you have cholesterol greater than 55 milligrams per deciliter in pleural fluid, and your lactate dehydrogenase is greater than 200 units per liter, with a ratio of pleural fluid cholesterol to serum cholesterol being greater than 0.3, you're more likely to be having an exudative state than a transudative state. So it brought light to, as you're using the papers they were more inclined to, they found that most of the papers that used both this other newer criteria using cholesterol, LDH, and plus the light criteria was more specific for you'd most likely be having an exudative state. So how do we manage pleural effusion? If you're going to want to do a thoracentesis, which is essentially our pleural tap, you could either be using it for diagnostic purposes or using it for therapeutic purposes. So you do this, and then you place a chest tube drain, to drain the pleural effusions, depending on what kind of pleural effusions they are, depending on how large, how small. You would also want to know what you're going to, the complications that are going to result from your draining. So one of the complications will be seeing bleeding. Bleeding, you can have an hematoma being formed. Yourself as a clinician, you could introduce infections. Your tube may be dislodged. And because of this, you want to find that as you're going to perform your thoracentesis, you want to get the best choice of chest tubes. Now, this is important because if you presume that you're more in an exudative state than transudative state, you may want to go straight for a surgical chest tube. That is a chest tube with a larger bore than going for a chest tube with small bore tubes. One of them, so for large bore chest tubes, usually used for diseases that have a viscous. For example, hemothorax, it all has this red blood cell components, or any complex exudative effusions, or if you have an empyema. If you have a pneumothorax, for example, or a transudative pleural effusion, or small volume effusions, you would probably want to use small bore chest tubes, which will be less invasive and less painful, and more to give more comfort to the patient. This brings us to when we use a pigtail versus a surgical chest tube. Sorry, Melissa, I think her network went off, but she'll be logging in. So you'd want to use a pigtail is less invasive. It's less painful. It gives the patient more comfort versus using a surgical chest tube. But then you need to know when you're going to use it.
Priscilla, if you can just send me the PowerPoint, you can project it from this side. Huh?
All right.
As you continue speaking.
Okay, so when we're doing a thoracentesis, I just want us to take us through a quick. I know most of us have done it. Most of us have done a thoracentesis, but there's some important aspects you'd want to look at. One is positioning. So there's that diagram there. You have a patient. You'd want to put the patient at the edge of the bed, and then they slightly lean forward, put them at a table, lean forward. And this is mainly if you don't have a good positioning, you risk injury to organs like intra-abdominal injuries. For example, the liver or the spleen, depending on what side of the pleural effusion it is. So you have this patient seated there, and you want to go at least 1 to 2 intercostal spaces below the height of the pleural effusion. So this is because you want to capture, you want to be able to drain, not all, but most of the pleural effusion, to be able to give the patient the relief that the patient needs. Usually it's in the posterior axillary line or the mid part of the scapular space, about maybe 5 to 10 centimeters lateral to the spine. And when you go above it, if you look at this picture, just slide to the right, knowing the anatomy that has been shared before, most of our vessels and nerves are just right below each rib. So you want to go just above the rib to avoid these injuries that could potentially harm the patient either in the immediate time or later on. So when you're doing this, you also want to Melissa, next, please. So you want to, as you're draining the fluid, we have some of the complications that come about when you drain the fluids, either a little too much above 1 liter, or too fast. There's one common complication that comes about, re-expansion pulmonary edema, which can lead to hypoxemia and respiratory distress, and can potentially be fatal to the patient. This is because the recommended amount is at least 500 to 1 liter at a time. The pathophysiology around it is not clear. However, it's mainly because when you drain so fast, there's that sudden shift in fluids. There's the sudden shift in fluids in the fluid. How can I call it? There's a sudden shift in the fluid. So you have this the lungs will re-expand and there's sudden overflow of fluid. This will lead to increased. So this will lead to increased either re-establishment of regional blood flow, which will cause rapid alveolar re-expansion. So your alveoli, remember, they had collapsed one reason or the other. So when you suddenly remove this huge amount of fluid, you have rapid alveolar re-expansion, which will increase your pulmonary capillary pressures. And this can cause pulmonary edema. Another school of thought alludes to the fact that you can cause mechanical alveolar injury, and this will increase, of course, your inflammatory markers, interleukins, and all the free radicals, which will destroy the capillary wall because of that, the alveolar capillary barrier, increasing capillary permeability. Then you have more fluid, for lack of a better word, rushing back into the lungs, and this will cause pulmonary edema. So these patients, you'll find that most of the time they'll start getting dyspneic, they'll have cough, they'll get very hypoxemic, so they'll need oxygen. They can be managed, but they have to have timely management. The other precaution you need to think about is the hemodynamic instability that will come due to sudden decrease in intrapleural pressures. So it's something that you want to manage, but do it slowly while you do. Okay, next, please. So when sometimes you've had these effusions that you're managing over and over again, you've tried to do the thoracentesis, your chest tube drainage, and sometimes it's not, the patient keeps coming with recurrent effusion for one reason or the other. There's something called pleurodesis, which is basically you're trying to attach the wall, you're trying to attach to reduce the space. So you want to introduce something that's going to cause some sort of fibrosis, and this space will be closed. So that's what essentially fibrosis is. So it helps you to close that space, and it can be done using a number of things. One of them being when you introduce talc powder. So you have your chest tube drain, introduce talc powder, or introduce things like DNases to try and just cause inflammatory reaction and adhesive reaction, so that you don't have any more space for fluid to recollect. And it's used in malignant effusions, especially because they usually recur, and kinothorax. So when another thing that you want to look at, pleural effusions can quickly move on to become empyemas. So if you remember, just a quick review about the different stages of empyema, you have 3 phases mainly. So you have the exudative phase, which is what we have been talking about. You have fluid buildup in the pleural space. So fluid comes in, and of course all the inflammatory markers, and then it enters the second phase, which is the fibrinopurulent phase, where you have fibrinous deposits coming in, and they don't come alone, they come with bacteria, and all these just form adhesions. And this is the stage where you may want to think about calling the surgeons in, because now it's in the initial phase. Usually the medical management would work in the first phase. So you're giving your antibiotics, you're trying to drain, but then if you've moved on to the second phase, which is the fibrinopurulent stage, you may require debridement alongside your antibiotics and of course the cultures and sensitivities. or decortication. For the third phase, where you have, it's called the organizing phase. So just like the term suggests, remember, we have the fibroblasts now are growing and having that the matrix are forming and they're getting thicker and thicker. And this definitely requires decortication. So if you are not sure about when to call a surgeon, then this is the phase which really would require a surgeon to come in and carry out decortication or to give the patient a chance to recover as soon as they can. So like I mentioned earlier on, the therapeutic option for empyema, initially you don't want to move on to surgery because we know that surgery comes with its own complications. So you want to get ahead of the infection control, give you antibiotics, do source control, so of course drain the fluids, and then one of the things that people are now using is having an intrapleural DNS alongside tissue plasminogen to resolve inflammation. So this it resolve inflammation. It has been found to have about 90% cure without surgery. So if it's something that can be done, I've never seen it being done. Maybe Dr. Erasmus has seen it being done, but if it's something that can be done, then it really helps with helping the patient cure faster than they would have if it hadn't been done. In terms of drainage, like I said, you do chest tube drainage alongside your infection control. But once you've reached levels 2 and 3, the phases, then you need a surgeon to come and do debridement and decortication. And they can do this using the video-assisted thoracoscopic surgery, or they could do open decortication. Okay, the other important pleural disease or pleural state that we want to manage is pneumothorax. If you can see that, that's just a pneumothorax. So if you have small stable pneumothoraces, then you want to observe. Not all of them, you need to intervene. So if they're very small, patient is stable. So what do you mean by stable? Saturating well, hemodynamically stable, then you would want to observe. Otherwise, if you'd want to continue your oxygen administration, so you're giving supportive therapy. And if it's a simple pneumothorax, you'd give your oxygen. If there are larger pneumothoraces, you want to place a chest tube. And of course, if it's a tension pneumothorax, then that's an emergency. You definitely want to intervene. Other modalities would be surgery, but most of the times, if you place a chest tube, then you'd be able to do that. And one important thing that I wanted to mention about pneumothorax is the mechanical ventilation strategies. Melissa, next. So mechanical, when you're ventilating a patient, most of the times, if a patient's coming and they're stable and they don't need mechanical ventilation, then that is good. However, sometimes we have these patients, for one reason or the other, either it's iatrogenic pneumothorax, or they came in with a pneumothorax that actually required them to be ventilated, or it's another primary disease, and somehow, due to the procedures we perform, a pneumothorax, they get a pneumothorax. But whatever reason it is, you want to do mechanical ventilation strategies. This is because of the risk of tension pneumothorax is high, because remember, we're giving positive pressure ventilation. So if you give this positive pressure, is going to increase the leak, and it can lead to a tension pneumothorax, which will either worsen or give the patient hemodynamic instability. It's common, of course, if a patient already has the underlying unstable hemodynamics, but it can also happen to a patient who didn't have one before. So what would you want to do? You want to carry out lung protective ventilation strategies. One of them being low tidal volumes. and the recommended was about 4 to 8 mils per kg, while maintaining good maintaining the state, the oxygen state of the patient. So you also want to give them titrated PIPs, preferably low PIPs, that is the positive end expiratory pressure. And one school of thought says you can use whatever ventilation you want. However, another school of thought says some people would prefer using pressure-controlled ventilation, because then you can control how much pressure is going in. I don't know, probably the audience would want to weigh in on that. The other thing is, because of the ventilator patient dysynchrony, you want to be able to adequately sedate this patient with plus or minus neuromuscular blockade. But I think sometimes adequate sedation is good enough, because remember, as the patient, when there's a synchrony, then you know that there's going to be worsening. There could be worsening of the pneumothorax, and which would give you the complication that I've mentioned above, which we wouldn't want. Sometimes, because of the different pleural, it's okay, Melissa, next. The different pleural diseases, we get what we call the bronchopleural fistulas, which basically it's a communication, a fistula is a communication from one space to the other. So this is because between the bronchus and the pleural space, and this could be because of a wide range of causes. So if you just see that, it's a wide range of causes ranging from, could it be trauma, could it be, infections, severe infections, and empyema that has eroded the area, and then you have that communication. It could be a tumor, and why it's one of those things that, because it can lead to, I think studies show about up to 60% mortality rate, I think from between 18 to 60%. So if it can be avoided, then that would be the best thing. We have looked at perpetuating factors being, next please, Melissa. So we have the factors that would worsen, that would lead to, that would worsen your fistula. Some of them are small, some are big, would be high inspiratory pressures. So if you have your kind of setting, your ventilator settings include high inspiratory pressures, then this worsens it. If you have increased intrathoracic pressures, for example, you've set a very high PIP, or you have increased inspiratory time, this would worsen the fistula. Sometimes even our own suctioning, the procedures we perform in the intensive care unit, like if you have high negative suction pressure, this could worsen the fistulas. What you'd want to do in this case, just like the pneumothorax, you also want to use different ventilation strategies that are going to optimize your patient. For the modes, you could use any of really, either it can be controlled, next is controlled or assist control, or even an SIMV mode. But notably, you want to go in the lowest tidal volumes and the lowest PIP. And if possible, you want to encourage spontaneous breathing. Now, if you have use of a double lumen tube, I'm going to put it up for those who have not seen it before. I know most of us have seen, but a double lumen tube is preferred. This is because when you see it, Melissa, just tell me, go down maybe about 2 slides, the double lumen tube. Okay. And the next one. Yes, so this is it. I don't know if it's clear enough. So this is the double lumen tube. If you look at it, you'll find that it has a bronchial part and it has a tracheal part. So the tracheal part comes and stops, just like their names, stops in the tracheal part, and then the bronchial part comes and it enters one of the bronchuses, depending on whether it's left or right. Yeah, so it helps to because you have a fistula in one side, if you have a double lumen tube, it's important because it helps you to kind of reduce the amount of air going into the affected side, the ventilation. Remember, I want to use the lowest possible tidal volumes and want to reduce the pressures going. That's what you don't enlarge or worsen the fistula. So you want to, and yet at the same time, you want to make sure the patient then go into severe hypoxemia. So it has, you know, both the two pilots here where you can deflate either the tracheal, inflate either the tracheal so that you have only ventilation moving mainly to the normal, for lack of a better word, the normal bronchus, and then you minimize how much is entering. Let's say, assume if the fistula was this side. So it helps you to ventilate the patient, but at the same time, giving a lung protection to the other side of the lung. Okay, Melissa, we can go back. Okay, so next one, just above. Yes, yeah. Thank you. So like I said, for large leaks, you want to do independent lung ventilation, and using a double lumen tube would be very helpful. Mainly it can be used in theater, it can be used in intensive care, but it minimizes further injury. Disadvantages, sometimes a double lumen tube, if you're not well versed with it, may be difficult to place. However, with time, it's something that helps with management. It has been said that high frequency oscillation may reduce peak airway pressures and reduce leaks. I don't know, I'm not familiar with high frequency oscillation, but it's a recommended, if you have access to it and if you know how to use it, then it's recommended. And they also say sometimes you may have to put the patient on ECMO to be able to manage the bronchopleural fistula. Again, I'm not well versed with ECMO. Maybe Dr. Erasmus will help us with that. So when would you need a surgeon? The surgeons would basically come in. Remember, you're ventilating this patient. You put your double lumen tube. You're trying to isolate. Sometimes maybe it's an infected lung, but you need the surgeons to come on board because one, you're trying to avoid disease spread. Sometimes it could be because one of the lungs, that part of the lung is severely infected, and if you don't do this, then it's going to spread onto the other lung, and remember, you're going to have worse outcomes. Sometimes you need curative treatment because you've managed the antibiotics, you put the chest tube, you know, but the patient is not getting better. However, you notice that sometimes it's just maybe just part of a lobe, you know, for a lobectomy or a pneumonectomy. So it's curative. You know that if this part is removed, if it's surgically removed, then the patient's actually going to get better. And then sometimes it's really recurrent infections. You have your patient comes in, you tap the fluid, they go back home. It's just in and out. Then sometimes you may need a surgeon to come in and address the underlying cause. Next, please, Melissa. So the one before. So in invasive management, there's also the rest were invasive but not that invasive. Some of the things that have been.
Doc, we're going to have Dr. Setabi talk a bit more on the interventional side. So I don't know if you might capture some of the things you're talking about.
Okay.
So maybe we can summarize the next minute or so.
All right. So in the next one, really, most of the others, the invasive management of the bronchopleural fistula, you may need to do endobronchial occlusion, but it's not feasible enough for multiple leaks. And then the surgeon would come in, of course, and do bronchoscopic repair that Dr. Setabi is going to talk about, and he will take us to the rest of the management, the surgery, the stamp stapling, and the decortication. Otherwise, for us as the medical side of the team, you would want to to go through just what I have shared about. I think that's it. Yeah, I think that's it. If you have any questions.
All right, thank you very, very much, Doctor. I know that we have really been patient, and thank you for being here all through. So we are going to have a Q&A for this after the final speech. But Dr. Michael Setavi, General Surgeon, currently undergoing cardiothoracic surgery fellowship training at the Uganda Heart Institute, is our final speaker for the day. He will take us through the interventional approaches relevant to the topic of the day. Kindly share your questions on the chat. Dr. Setavi, you're welcome, and thank you so much for heeding our call to join us today. So over to you. Share your and start.
Thank you very much, Dr. Erasmus, and I thank you for the opportunity for allowing me to be part of this discussion. The beauty of it all is that most of the work that I had to present has been presented by either one of the facilitators of the day. So, Dr. Erasmus, I shared with you the PowerPoint. I think we can start with slide number 5 in the interest of time. But as they share the PowerPoint, why I asked my colleague from radiology the difference between the chest X-ray in somebody who has subcutaneous emphysema is that most of the times the pneumothoraces are masked. So somebody will see a chest X-ray, they may appreciate much more of the subcutaneous emphysema, and they miss out on the hemopneumothorax. So I think it's always important to have a high index suspicion of hemothorax, especially in trauma in patients that have a subcutaneous emphysema. As Dr. Erasmus is sharing the slide, I can really discuss my topic here briefly because most of the information has been discussed. But basically, I would want to know why would we have to intervene in patients that have effusions or patients that have a pneumo or air in the pleural space. So the indication really for thoracocentesis has been discussed. You can start from slide number 5. Dr. Erasmus, you can start from slide number 5. Basically, mostly...
Slide 5 talks about contraindications. Let me see if I got you right.
That's number 6. Slide number 5. Okay. The indications for thoracocentesis. Basically,
right,
a patient has a effusion, and on lateral decubitus radiograph, you're getting more than 10 millimeters thick of unclear cause. In patients, we are having that usually have congestive heart failure or on diuresis more than 72 hours. They're not improving, they have fevers, usually it's unilateral, there's usually a significant macular symmetry. And most of these patients have a cardiomegaly, or they may not even have a cardiomegaly. You may have to do thoracocentesis. Most times you have given them medical care, but still you have fluid accumulating in the space. And also for other therapeutic intervention, especially in trauma, when you have fluid that has accumulated, blood that has accumulated in the pleural space. We need to know, as we choose to carry out these investigations, we need to know, these interventions, we need to know if we have relative contraindications. Patients on anticoagulation or have a bleeding diathesis, you have to be careful on intervening or not intervening. Dr. Cornelius will tell you we have had patients with a very high INR, and you're wondering, should we go in and tap the effusion? Will the patient bleed? But they're getting, they have a complete lung collapse. You have no air entering. You really need to expand that lung. So damn if I do it, damn if I don't do it. Okay. Now, the patients also have very small pleural effusions. Now, patients with very small pleural effusions, mostly they can benefit from medical care or medical management without necessarily intervening. Patients that are on mechanical ventilation, they have a high PEP, you really want not to do what? To intervene and do what? A thoracocentesis. And also patients that have an active skin infection at the site of insertion. Most likely, if we are inserting these chest tubes blindly, we use the triangle of safety. So if you are going into the triangle of safety and there is active infection, you are likely to introduce it into the pleural space, likely to cause a mediastinitis and other overt complications from doing this procedure. So you should not really put a chest tube. And that's when we advise for ultrasound guided drainage. And you can look for an alternative site which has no infection, where you can put your needle or tube under guidance and you drain the fluid or the air that will be contained. Now, when we choose to carry out surgical management for these patients or surgical intervention, we need to know if the patient we're dealing with has a transudate or exudate. And definitely transudate, we treat the underlying disease, and the exudate as usual, depending on the etiology. I don't want to go back to the things that most of my colleagues have already mentioned. But the patient who is symptomatic with an effusion, we have to do therapeutic thoracocentesis, okay? But then we have those effusions that are complicated, where we need to intervene by having a tube thoracostomy. Now, the simple effusions, we can use Pigtail catheters to drain the effusions, especially like parapneumonic effusions that are secondary to a pneumonia. The fluid is clear. You can easily put a pigtail or a small tube and drain them. Or sometimes, like for effusions because of cardiac failure, mistakes cardiac failure, you can even do a needle thoracocentesis and drain the fluid out. However, for the patients who have, for example, congestive cardiac failure or recurrent effusions, you putting a needle thoracocentesis is just a stopgap measure to improve your SATs, your SpO2 as you try to expand the lung, but it doesn't take away the fact that the effusion is still being recreated. So the main intervention then becomes you need to put a tube thoracostomy. Now, tube thoracostomy, we know clearly the triangle of safety, anterior axillary line, posterior axillary line, fourth, fifth intercostal space. However, we can also put the chest tubes in different positions, especially if we have direct vision or radiological guidance. So you'll have some people put them a little posterior. You can put them at the subxiphoid area, especially if you do a sternotomy, you have finished your surgery, you can put it via the subxiphoid area. You have done a thoracotomy, you have direct vision, you can put it a little more anterior or a little more laterally. And you can put it at a space lower than the fourth, fifth intercostal space. So the triangle of safety is basically for somebody to go where they think they are safe blindly. But that doesn't necessarily mean that it's the only place where we can put the chest tube. In some large loculated effusion under ultrasound guidance, we can either put pigtails or we can put chest tubes, especially for the empyemers. That will help to drain the fluid. In some patients that have, I know my radiology colleague presented something about complicated effusions. In some of those patients, we may need to do a thoracoscopy. I'll share some of the images of the thoracoscopy. But in the thoracoscopy, basically, we are doing the laparoscopy in the chest. Small incisions, putting cameras down so that you can be able to visualize what is in the chest. And for that, basically, you're trying to break down the adhesions, especially for multiple loculated cysts, and then you can be able to drain the cysts. But this thoracoscopy can also help you to decorticate. I know the previous speaker was talking about decortication, to decorticate or to remove the thick pleural peel that is holding down the lung, causing a fibrosis or a collapse, especially in patients that have empyema thoracis. So in thoracoscopy, we can be able to get that peel off. Now, and also through thoracoscopy, you can do wedge resection, especially when you have, she mentioned patients that come in with a bronchopleural fistula. You can do resections of areas that have a fistula, and you do staphoid anastomosis. That helps you to sort the bronchopleural fistula. Now, when you put the chest tube, and this is, I think, important for us to discuss, that when a patient has a chest tube put, we need to look at what is going into the underwater seal. If it's pus, if it is chylothorax from chyle collection in the chest, thoracic cavity, following thoracic duct injuries or tumors, you need to know what is contained. And if you have persistent collection of the fluid consistently, then you think this fluid is still coming, we need to intervene. And that's when you do what we call a pleurodesis. So pleurodesis basically is an intervention that causes irritation of the pleural walls and causing them to inflame and adhere together. So it can either be mechanical pleurodesis or it can be chemical pleurodesis. The previous speaker was talking about the use of talc and also bleomycin, doxycycline, as agents that are chemically introduced into the chest cavity so that they can cause pleurodesis. As a rule of thumb, never pleurodese a patient without a complete expansion of the lung. So you put your chest tube, you have to be sure that the lung has fully expanded so that you pleurodese. If you pleurodese a lung that hasn't fully expanded, you'll have a gap, so the epithelium will continue producing a fluid, and hence you'll have now fluid accumulation that will lead to lung collapse and further complications for your patients. Now, we can also do mechanical pleurodesis, and in mechanical pleurodesis, you, via thoracotomy or thoracoscopy, you peel off the empyema peel or the thickened peel. So after peeling off the peel, the inflammation that will occur will cause the two layers of the pleura and then the lung to adhere together and heal still with fibrosis. Henceforth, we'll have an expanded lung and there is no potential space within which fluid can accumulate. Now, apart from thoracoscopy, we can also do what we call an open thoracotomy. And the thoracotomy or accessing the chest is usually a posterolateral incision, but we can also have lateral incisions. We can go supraaxillar area, depending on what you're looking for and the area of the chest you want to go into. But that is not anywhere different from a thoracoscopy. But the main aim of that is for you to access the chest and remove as much of the peel as possible so that the lung can expand. And that is usually an operation of choice if thoracoscopy is contraindicated or there will be difficulty in doing the thoracoscopy. You would prefer doing a thoracoscopy to an open procedure in very sick patients or patients who won't be able to undergo prolonged procedures and also need a lot more care postoperatively. So you'd want to minimize on either of the two procedures. Now, the chest tubes in pleural effusions can be put by any doctor, provided they are trained to put the chest tube. It doesn't necessarily need a surgeon to go and put a chest tube. And I thank Dr. Erasmus, because in their ICUs, we find these chest tubes already put. And we only come in when the chest tube is not draining, it is blocked. What do we need to intervene? Can we do more than people waiting for a chest tube to be inserted? Now, I'll discuss a little bit of about the pneumothorax, but I know it has been mentioned by all the previous speakers, but I would need to mention that we have pneumothoraces that are spontaneous, and then those that come because of that are acquired. Now, the spontaneous pneumothoraces that we usually talk about can follow rupturing of the alveoli, causing what we call subpleural blebs. Blebs are usually less than 1 to 2 centimeters intracavity lesions that are collecting air. And those are usually primary. But you can also get bullae or bullous lung disease, like the X-ray that was shared by our colleague from radiology. And that will be an expansile area of air in the pleura, in the parenchyma of the lung. It is very important for you to clearly identify and differentiate between bullous lung disease and the pneumothorax, because many people sometimes go in and put chest tubes and then they cause fistulae in the patients who have bullous lung disease. So it's advisable for all of us to go back and look at those X-ray images of bullous lung disease so that we don't make mistakes. However, the bullous lung disease usually follows patients that have chronic obstructive pulmonary disease, emphysemas, some people with type 1 antitrypsin deficiency, emphysema, usually give us bullous lung disease. But you may still also get patients that have cystic diseases, like from cystic fibrosis, in lymphangioliomyomatosis, it also can happen, but also in malignancies like primary lung cancer, small cell cancer, sarcomas. But the common one that I wanted the audience here to pick is the catamenial pneumothorax. Now, catamenial pneumothorax follows an endothelial-like lining on the pleura or on the diaphragm, causing patients to have cyclic pains that follow the periods. So basically, these people bleed within the chest cavity, or sometimes get pneumothoraces in the chest cavity that are following the cycle. So many patients will come recurrent pneumothorax, but it comes around the time they're getting their periods. And we have it's common in light-skinned ladies, fairly looking. So those are good patients that we need to catch. And they're the ones that will benefit mostly from a pleurodesis after draining the hemopneumo or the pneumothorax and the lung expand. Those ones have to benefit from a pleurodesis. But basically, we can also get it in patients that have infectious causes like SARS, PCP. They all can get pneumothoraces, and commonly also in connective tissue diseases like in Marfan syndrome. But it can also be caused by us, the medical people, those who get acquired pneumothoraces, especially our colleagues from anesthesia as they are putting their central lines. uh, but also from biopsies, radiology, intervention radiologists, and also the surgeons as we are doing biopsies, but also even the needle thoracocentesis can cause many a times to get these complications. Some friends of ours from pulmonology, as they are doing their bronchial biopsies, they can also still cause perforations and pneumothoraces. But the common ones that we have had are usually due to trauma, both blunt and penetrating trauma, but also our colleagues from anesthesia, the barrel trauma, can also cause pneumothoraces that are ventilator induced. Now, for the bullous lung disease and the blebs, we can go via thoracoscopy and we have wedge resections. But however, for if patients are asymptomatic, you have seen it incidental on a chest X-ray, they have just come for clinical examinations and assessment, maybe for a job they are starting, and on the X-ray you find a bleb or bullous lung disease, they are symptomatic. Most of the times you monitor the patients, but you can also do needle aspiration and drain the air, okay? So we only intervene to do thoracoscopies or thoracocentesis. Thoracotomies when we find significant disease that needs us to go in and resect. So, but apart from that, most of those patients, you monitor and see how they are responding. Now, in some of the patients, we need, I'm in a presentation, apologies. In some of the patients, I don't know, Dr. Erasmus, we failed to project the slides. I wanted to show you areas where we can intervene as emergency, in emergency situations when patients have a tension pneumothorax. Because a tension pneumothorax is a condition that all doctors should identify. And it's one of the thoracic emergencies we get. So a needle is inserted in the second intercostal space, mid-clavicular line on the left. Okay, so as you insert your needle, you aspirate so that you can be able to open out and air comes out. It's usually the primary intervention for tension pneumothorax, but as the lung expands, you then go ahead to put in a chest tube for that patient. Until at least more than 24 hours, you have clear lung expansion, no air is still coming out, then you can have your chest tube removed. However, for patients that get recurrent pneumothoraces, those are the patients you should also 4 days after expanding the lung, because most of those patients will surely come back to you with what? With the need for a surgical intervention. I don't know, Dr. Kello, Erasmus, if I've rushed through, but I thought I could rush through in the interest of time so that I can cover what my colleagues didn't cover. I thank you all.
This is lovely. Thank you, doctor. Thank you. This is quite great. All right. Thank you so much, Dr. Setabi. I know, like they say, a great chef will always serve just a little, enough to stimulate you to want to come back, to have a little bit more. So this conversation is just an introduction, and definitely should continue, not just here, not just in the chat, but even after the session. So thank you very, very much, Dr. Setabi, for joining us, and thank you, Dr. Priscilla, for taking us through the medical management or non-intervention, non-advanced interventions to diseases of the pleural space. I welcome quick questions. We are already well past our usual time, and just welcome questions from everyone quickly before we, we close. Any questions? All right, so Dr. Cornelius, could you kindly project those poll questions so that we just give them a quick response and we conclude? Dr. Cornelius, are you on? All right, so just in the meantime, there are questions that are projected earlier on that we had a shot at. These questions are derived from that paper that Dr. Priscilla talked about, the rational clinical examination by JAMA. A few years ago, JAMA kept running this series talking about every clinical sign we handle in medicine. And I thought I would bring it in because we do a clinical exam of patients. I don't know how many of us nowadays elicit tactile parameters, how many of us test for vocal resonance. I don't know how many of us do that, those amazing clinical signs in medicine. Or maybe we're just quickly rushing patients to imaging these days and so missing out on the auxiliary medicine. But for each of the clinical signs, it's a different predictive value. So for sensitivity, reduced tactile parameters turns out to have a much higher sensitivity, certainly not too far away from the aspect of dullness to percussion, although dullness percussion may not be as sensitive compared to dullness to what we call auscultation percussion. You can look up how to perform auscultation percussion. It's a lot more sensitive than just a regular conventional percussion. In differentiating between pleural effusion plus other things that could reduce the transmission of sound. So in terms of sensitivity, reduced tactile parameters is a much higher sensitivity. The least sensitivity is the pleural rub, the friction rub. It has the lowest frequency. However, it has the highest sensitivity, specificity, meaning that once it is actually present, it suggests that there's an effusion. However small it might be, it is a lot more predictive. The rest are not exactly too poor at being specific either, but there are many other things that can interfere with the rest of the clinical signs. But the pleural friction rub being present is specific for pleural effusion. And then finally, in this particular question, we did have, we were asking for a most predictive sign of a complicated perfusion that might need an intervention right from the outset. In other words, sometimes you can intervene and on evaluating the fluid, it looks kind of transudative, it looks clear because some of the sediment might have settled down or maybe it's not very visible to you. And so you're wondering whether just to leave it and just diurese the patient. But once you test you analyze the fluid and you notice that the pH is less than 7.2, that's a fluid that is accumulating acids from metabolism, either lactic acid or CO2, among other things, from metabolism by bugs, and therefore it's very predictive of a complicated effusion, particularly an infected one that will need you to put in a chest tube in the patient early enough. Certainly, if it's in the early stage of empyema formation, which is just the parapneumonic effusion, then maybe you can just use diuresis, use antibiotics, and the patient will get better. But if you notice that it's getting to the fibroproliferative stage or the fibrotic stage or the organizing stage, then surely in that case you need a chest tube. I thank you for attending to today's session. It's been rich and clearly the fact that we've gone beyond our time suggests that it's been a lot of work to discuss, a lot of stuff to put across, and I'd like to send a vote of thanks to especially our colleagues who are joining us from other specialties, Dr. Eyotaro, Fiona from radiology, and Dr. Eden Michael Setabi from surgery. These are guys who work with, these are the specialists that we call on to hold our hand sometimes when things are going the right way with the usual things that we are trained to do. And sharing skills, sharing knowledge is always key. Like I mentioned earlier on, I implore each one of you to go ahead and have a chat with radiology, especially so you understand how to diagnose these things. Because unlike many of us who are lucky to work in upscale places, not shithole places, we can have a radiologist on call and just say, hey, take a look at this, give me your feedback. Some of you are going to end up working in some remote place where you're the most highly educated person in the whole district. And I mean, you have no one else to follow you for help. And you need to get a bit more skilled in interpreting these images. And so many people are dying with abnormal images in the community because the doctor doesn't have a clue that what they are seeing is actually bad. Pleural diseases and pleural space is really an enabler and a perpetrator of cardiorespiratory dysfunction, being a dumping ground for diseases right from the lung to the lung to the heart to the kidney, the liver, even to the gut, even to things to the bone marrow and so on. All things can end up in the pleural space, and so you really need a clear diagnostic approach to determine what's going on. And many times, diseases of pleural space will present, as we have been taught, with issues of air, water, chyle, pus, blood accumulating. Certainly, you can also have a tumor and other things, but these are commonly the leading things, and maybe acute or maybe chronic, and simple, complicated, or life-threatening. And so determining and classifying quickly helps a lot. As you may notice from the presentations, there may be some limitation diagnostics and maybe some confounding, maybe some confusion. You need to be able to keep yourself well to catch them quickly. Management, for the most part, may vary from as simple as just watchful waiting as you solve other issues, or you may actually have to intervene either medically or with an intervention. And primarily, do not forget to determine the underlying cause. Thank you so much for being here and waiting all this long. So next week, we will be switching to the infectious diseases of the lung. We're going to be dealing with the bugs and the lung, and we shall have quite another big cast. Very interesting conversations to hold at that time. So kindly go ahead and rest this weekend, catch up with your dates, and please go home with a gift for them. Dr. Setabi, we had someone speak in the background. Ensure that you atone for this missed time, and tell a colleague about next week, and bring a colleague over, read up, start with infections of the lung, and let's have a fruitful, rich conversation. Thank you, and goodbye.